It gives me great delight to introduce our inaugural Griffith Outstanding Equity Neuroscience Mentor awardee. So Dr. Griffith, who passed away in 2024, was a mentor of mine. He just was, I didn't ask to be, he just kind of adopted me, for which I was very, very grateful. I would see him at meetings and he would say a kind word, give me encouragement for the work I was doing. When I visited Morehouse School of Medicine as visiting professor, he was the most magnanimous and gracious person. I made that 3-day visit fantastic. And I know I speak not just for myself, but for so many people who were privileged to be exposed to his kindness and humility. He was one of the very first Black trained neurologists. And as you can see on the screen, he moved from Guyana to the US to rejoin his parents who had immigrated here. And then he became a naturalized citizen, enrolled in medical school at Howard University, and then subsequently became a neurology resident at the Peter Bent Brigham Hospital, one of Harvard's teaching hospitals back then. Of course, that's changed now in terms of nomenclature. But he then was commissioned in the US Air Force during his neurology residency, served in the US Army Reserves, rising to the rank of colonel before retiring and having earned an Army Commendation Medal and 2 Meritorious Service Medals. He was chair of the Department of Neurology and director of the Clinical Research Center at Meharry Medical College, and also was lead investigator on studies of Alzheimer's in Blacks. He was a well-renowned expert in diagnosis management and treatment of dementia, especially vascular dementia and the prevention of stroke in people of African ancestry. And a lot of the work that he did laid the groundwork for a lot of the work that was done subsequently. Dr. Griffith taught many students and cared for patients for over 40 years. He spent time at Emory, at Grady Memorial Hospital, at Morehouse, as I mentioned, and also when he retired from Morehouse, spent time also at the University of Texas Southwestern in Dallas. Dr. Griffith was president of the Clinical Neurological Society of America from 1996 to 1998. And so we are honored and privileged to have Dr. Griffith's son and daughter here, Dr. Derek Griffith and Melody Griffith. Thank you for gracing us with your presence. Again, we hold your father in very, very fond memory. And so having said that, I will then move to the 2025 Patrick A. Griffith awardee. And so a lot can be said about Dr. Saylor, but she's a phenomenon. And I'm sure you'll see that from her presentation. But currently, she's Associate Professor of Neurology at the University of North Carolina. She's chair of the Global Neurology section of the AAN. She's vice chair of the Global Engagement Committee of the ANA. She's president of the World Neurology Foundation and also clinical chair of the Multiple Sclerosis International Federation for Essential Medicines panel. Dr. Saylor has just done phenomenal work in Zambia, and I don't know what she's going to talk about. I think I have an idea of some of it, but she did pivotal work in creating a residency program, a stroke unit from the ground up. When we read the letters that her mentees wrote, we were all moved to how much of an impact she's had already on their careers. And so without further ado, I want to welcome Dr. Saylor and congratulate her for this wonderful and much deserved award. I want to invite Dr. Griffith to come on board too as well, so we can honor both Dr. Pat Griffith and also Dr. Saylor at the same time. And do I have the award here? Yes, I do. All right. All right. So I'll take one. Thank you. And then with feel free. Thank you. Thank you. All right. So Dr. Saylor is going to talk about mentoring in low and middle income countries, pathways to improving global neurological equity. Let me pull up your slide.
Thank you so much, Bruce, and thank you for this amazing honor. It's quite humbling. It's also, I have imposter syndrome to begin with, and now to give a talk on mentoring after all of these talks from such amazing senior mentors in the field is quite intimidating, but I'm happy to be able to be here and just share some perspectives that I have. So very briefly, I think I just want to start by saying I feel like I have really big shoes to fill. I unfortunately was not lucky enough to know Dr. Griffith, but in talking to others who've known him, it's apparent that he was just an incredible man. So Bruce has already highlighted a lot of what I wanted to say, but to start with, I've included his name in green because I hear that that was his favorite color. And not only was he an amazing neurologist and mentor and researcher, but he was a husband, a father, grandfather, uncle, great uncle, and a dog father as well, from what I understand. He was an active member of the Church of Incarnation in Atlanta for more than 50 years and sang in the choir. Bruce mentioned he was born in Guyana in South America and moved to the US when he was 17, completed undergraduate studies at McGill, medical school at Howard, and then we heard internship and residency at Harvard, and we heard about his service to our country as well. We also heard about all of his academic appointments and contributions at Emory, Meharry, Morehouse, as well as the Clinical Neurological Society of America, and the work that he did on dementia, particularly vascular dementia and stroke in Black Americans. And I understand that his work extended to the Caribbean as well as to Ethiopia. So it sounds like he was just an incredible, incredible person in so many different facets. And from what I understand, his mentees were too many to count. I have a mentor, Gretchen Burbeck, who likes to talk about mentee families. And so just two of the mentees of his, Dr. Mitzi Joy Williams and Dr. Mahari Gabriel Hans, are sort of my cousins. And so I think he was my mentoring uncle, even though we never had the chance to meet. So it's such an honor to be the first recipient of this award named in his honor. And not only is it an honor because of that, but also because I understand I was nominated for this award by mentees of mine. And I think there's just no greater honor than to be recognized by the people that you train and that you develop relationships with over time. And so I'm just incredibly honored to be here. So I'm going to talk to you today about my reflections on mentoring, on how to be a good mentor, and why I think in particular it's important to focus on mentoring in low and middle income countries. And in order to do that, I think there's so many different things that we think about in a mentor. And so just making sure we are talking about the same thing, I wanted to go through some different definitions of being a mentor. So one definition I found is a long-term relationship through which a senior or experienced individual supports the personal and professional development of a more junior colleague. Another one, a person who guides a less experienced person by building trust and modeling positive behaviors. And a dependable, engaged, and authentic individual tuned in to the needs of a mentee. And so when I look at these definitions, which are all a little different, several things stand out. So a mentor is a senior or at least maybe more experienced individual. We see that in both of the first two definitions. And then there are some important actions. They guide and support their mentees. And they have different attributes as well. They're dependable, they're engaged and authentic. And they build trust, they model positive behaviors, and they're tuned into the needs of a mentee. So your mentees are not meant to be your copies, right? We as mentors are meant to really understand what needs our mentee have and do everything we can to help them achieve their goals. And mentorship has many, many goals and aspects. So this is one graphic of common elements of mentorship that you often see. So there's coaching, helping people to develop the skills that they need, supporting them in their needs, helping them to set goals and then achieve them, helping to provide the training that they need to achieve those goals, motivating them, giving them advice, helping them to succeed, and giving them direction. And this is a lot to ask of a mentor, right? It's a lot of things to do. And so I think it's important to remember that generally we don't have one mentor, and generally we can't be the only mentor for someone. It truly does take a village, and there are many different types of mentors. So you can have a research mentor, you can have a clinical mentor, a career mentor, a mentor on work-life balance, a peer mentor. They're all different kinds of mentors. And I think it's important both as a mentor and also a mentee to realize that we can't be everything for everyone. And so now I want to just take you through my own mentoring journey and the lessons that I've learned that I think are important for all of us. So many of you, some of the Transcends graduates, you're just starting out. And I think one of the things that really helped me was serving as a junior mentor, where I still had a more senior mentor that I was going to, that really helped me to learn how to mentor. Mentoring is not something we innately know how to do, and it can be really helpful to have guidance as we ourselves are learning to be mentors. One of my mentors, Dr. Ned Sackter, helped me do that when I was a fellow, and I was able to mentor Maria Molinaro, who was a medical student at that time. She's now a senior pediatric neurology resident at Johns Hopkins. And I was able to work with data that I had gathered with Dr. Sackter and help her to analyze and write this paper that ended up for her as a first author publication in the Journal of AIDS. And you can see here that Dr. Sackter allowed me to be last author on that paper, even though it was really his study. And so again, realizing that how important it is to promote your mentees and give them opportunities. I think one of the lessons that has always been really important for me is that you don't always have to feel qualified. I still don't feel qualified even to be up here standing here today, but recognizing that we often are qualified and that imposter syndrome is real. And this is one of my, I think one of the stories in my career that has really taught me this is my relationship with Dr. Aparna Nutaki. So I moved to Zambia almost 8 years ago. I was in my second year as faculty, so I was a very junior faculty member. I was developing a neurology training program in a country that had no neurologists and developing clinical services, and pretty much in over my head in almost every aspect of my work, and had virtual mentors. Essentially at that time, there was nobody there that could really help. And Aparna was a medical student at the time, reached out to me to say that she wanted to take a year off. She had funding and she'd like to come work with me. And I was thinking, oh my goodness, can I really mentor someone for a whole year, have them move across the world to come work with me? Am I ready for this? And I had actually heard through the grapevine that she had met with a more senior person in her own department who will remain unnamed, but told her that it wasn't a good idea to come work with me, that I wasn't a very established researcher, and that it probably wouldn't be a very successful year. And so I remember agreeing to take her on and feeling like, oh my goodness, now I not only have to prove to myself that I can do this, but to other people as well. And Aparna not only stayed for that year, she ended up staying for a second year. She and I still work together. This was in 2018. And in the past 7 years, these are the different awards she has earned, but with me as a mentor. And so you can see that it turned out to be okay for both of us. And so I think just remembering again, you don't have to feel qualified. You don't even have to be perceived as qualified to do a really good job mentoring. And I think, recognizing that mentoring takes a lot of time, right? To do it well, it takes a lot of time, especially in the beginning. It takes a lot of time in the beginning to establish that relationship with your mentee. This is a real relationship, just like any other relationship in your life that takes time. It also takes a lot of time to help them gain the fundamental skills that they need to be able to do the work. And hopefully it's not the reason that you're doing it, but it's important to remember that mentoring can have substantial career benefits, not only for your mentee, but also for you. So this is some data I found that shows that mentoring benefits mentors as well. So people who mentor are 23% more likely to advance in their careers. They also are more likely to report higher levels of job fulfillment. They are less likely to report anxiety and other mental health issues. And they're actually more likely to be efficient at their jobs. And I think going with this mentoring relationship with Aparna, when I moved to Zambia, and still currently, I'm actually a neuroinfectious disease, neuroimmunology trained physician. But Aparna's initial work with us was to just help us understand who we were seeing in this brand new neurology service in this country that had never had neurology before. And the first and biggest finding from her work was that 45% of the patients admitted to our service had strokes. And not only that, they were doing really poorly. Inpatient mortality before we started the neurology service was 48%. And so suddenly my whole research program shifted. And now people think I'm a stroke neurologist. And I always have to qualify that I am very much a fake stroke neurologist. But for the past 8 years, we've worked on understanding the stroke burden in Zambia and improving those outcomes. And this work with Aparna has resulted in multiple publications and the preliminary data that helped me to earn my K award and now go on to submit for ours. And so again, I think it's important to remember that this time we're investing is a lot of time, but it does come back to also reward you as well. And then I think, again, in thinking about how our mentees are not always copies of us, or maybe won't pursue things in the same way that we would, I think with creativity, you can find something for your mentees that match their interests and also their availability. So this is Aisha Mahmoud. She's a medical student at UNC who came to me and said, I'm really interested in doing global neurology work, but for personal reasons, I'm not able to travel and come to work with you in Zambia. Is there anything we can do? And so we worked together to realize that maybe a systematic review looking at the efficacy of stroke units in low and middle income countries would be a good project. And she was actually able to achieve an AAN Medical Student Research Award for this proposal. So not something I was thinking of doing prior to meeting her, but something that will be useful for both of us. I think it's also important to recognize that mentoring relationships change over time. So this is Dr. Morgan Prest, who's currently neuro ICU faculty at Yale University. I actually first met Dr. Prest when he was a third-year resident at the Partners program in Boston, and he came to Zambia for a 4-week clinical elective, and I became one of his clinical mentors. But then he approached me about coming back to Zambia to pursue a research project, and we were able to work on this project looking at aspiration pneumonia in Zambia. And then he approached me to say that he'd like me to continue to work with him as a research mentor. And we were able to publish several other projects, even though he was going into neurocritical care. I was not neurocritical care faculty, but was still able to work with him on this. And then most recently, we've now developed the relationship where he's now the junior mentor, mentoring some of our Zambian trainees, and was able to publish this with them. And I think not only do mentoring relationships change over time, but mentees can also become your mentor over time. So many of you may know Jennifer Idrisi, who's movement disorders faculty at UCLA. Jennifer was another one who I met when she was a resident. She came to Zambia for a clinical rotation, then got a grant from the ANA to come back and do a Parkinson's disease project. And I've been lucky enough to continue to mentor her over several years. But at the same time, Jennifer is amazing with community engagement, community participatory-based research, and has really helped to teach me and mentor me as I have begun to expand into those aspects of my work in Zambia. So again, not that we do it because it benefits us, but also there are many, many personal benefits to being a mentor as well. And then I think just remembering that it's important to take a chance on people, especially when they come from places with fewer opportunities. So this is a picture of Satchel Sahel. He's now a public health researcher and physician in Pakistan. He was one of the many people who send me emails, like Bruce was describing, who said, "Can I come spend a summer working with you?" He knew about my work and asked if he could come spend some time. And so he came and spent a summer, and we worked together on this project looking at headache in a cohort in Uganda. But again, I didn't really know much about Sahel. He sent me a CV. It was okay, but I knew that he hadn't had a lot of opportunities where he was coming from, and so decided to take a chance and was able to mentor him on this project, wrote a letter of recommendation for him to get into Cambridge University for public health, and he's continued to excel. And I think that this concept is really, really important when we think about mentoring in low and middle income countries. So this is a table. There was recently a supplement on global health mentorship that came out in the American Journal of Tropical Medicine and Hygiene. And this is a table that is probably hard to read, so I apologize, but really talks about why this is important and what are the challenges in LMICs. And it compares high-income countries to low-income countries. And so the first and the obvious one is the availability of mentors, right? We have lots of faculty in our respective universities and hospitals. When I moved to Zambia, there wasn't a single neurologist in the country, right? And so you have fewer mentors available. And then there's not the same culture of mentoring, right? Mentoring is expected of us as faculty in the US. It's a metric upon which our promotion is based many times. And that's simply not the case in LMICs. In general, in training in LMICs, it's quite hierarchical. It is I am the teacher and I will impart my knowledge on you and you will not question me. And so this bi-directional kind of horizontal learn from each other relationship doesn't exist, which makes mentoring relationships more challenging. There are very few institutional resources to support mentoring in LMICs. And then there, again, it's just not an institutional priority in many places. And so even amongst people who want to be mentors, the awareness of what and how to mentor, resources for providing training for mentoring don't exist. And it's not just the mentors who face barriers in LMICs, the mentees face barriers as well. So again, this culture of research is lacking, which means that students, residents, they may not even be aware of the opportunity for mentorship, for research. And so that limited awareness may be perceived as limited interest or a lack of interest. They also have limited research training and experience, which means that that upfront time of developing your mentee is even greater. And then there are very few programs that provide dedicated research time or training. So we'll hear about the Talents program soon. That's one of very few. There's often no research electives during your undergraduate training or during your postgraduate training. There's higher clinical demands, which make finding time for research even more challenging. And then there's a lack of research training courses during training and few opportunities to pursue formal research training through things like a T32 that we have in the US. And then there's very few funded opportunities for research experiences at any point in the career stage. And so all of this makes it more challenging for LMIC trainees to pursue research mentorship in particular. But I think it's really, really important that we mentor these young physicians in LMICs. There are practical aspects. So making sure that they are mentored improves the quality of the research they conduct. It increases the impact of research, and it also leads to improved implementation of findings and research outcomes from the research that is conducted. But I think there's long-term, more ethical reasons to improve mentoring as well. Obviously, this increases capacity building. It trains the next generations of scientists who can answer questions that are important to the populations with whom they work in contextualized ways that make sure it answers the questions in a way that they can be implemented. It also leads to equitable global health partnerships when the power of knowledge, the power of experience is distributed equally. And it advances LMIC priorities and ownership of the results when they are empowered to be included in the process. And so I think this is something that I've spent the past 8 years of my life doing, is not only training neurologists in Zambia, but training them to be researchers if they're interested in that. Because again, I think that this is the first generation of neurologists Zambia has ever had. They are the future of neurology in Zambia, and they need to be equipped to ask questions that matter and to answer them in ways that matter to the Zambian people and to the environment in which we work. And I've been really lucky to have really brilliant, dedicated trainees. Dr. Mashina Chamba was one of the first graduates of our program, is now neurology faculty at the University of Zambia. He's received a UJMT Fogarty Scholar Award, as well as a Dupree Award from the Multiple Sclerosis International Federation. Dr. Stanley Zimba is also one of the first graduates of our program, also received a UJMT Fogarty Scholarship, recently completed a PhD in neurosciences from the University of Zambia. Dr. Lorraine Chishimba, also a UJMT Fogarty Scholar, has been elected to the Executive Committee of the Movement Disorders Society African Section. And Dr. Melody Asukile is currently pursuing a PhD at the University College of London, doing her work in Zambia, and I'm lucky to co-mentor her on this, and is a recipient of the Mandela Rhodes Fellowship. And so I think, and these were just a few of the many people I've been lucky to mentor in Zambia. And so I think in my experience, the keys to successfully mentoring trainees and LMICs is first to have a plan to provide a basic research foundation and additional support. Because again, they haven't had the same opportunities we have. So when I developed the Zambia Neurology postgraduate training program, I built a weekly research method seminar into the curriculum. So we could talk about study design, study methods, data collection, basic analysis. I still provide lots of help with biostats and I provide them with writing guides for papers and grants, but really giving them that structure on which to build. I've worked really hard within our program to build a culture of asking questions and working collaboratively. I still remember the first day on rounds when someone asked me a question and I asked them back, well, what do you think? You know, and that had just never been done. Normally the consultant is the one who knows everything, and to actually ask for input or admit that you don't know something was not a model that they had seen. But we also, again, we have the weekly research method seminars. We also have weekly journal clubs. And then any dissertation project that one of our trainees takes on, we take that on as a neurology unit project. We have a WhatsApp group to help with recruitment for that. We make sure that that project is successful as a unit, and the whole unit buys in. And the whole unit sees that those questions then directly impact how we take care of our patients and improve our patient outcomes. And then they're excited to ask their own questions and start their own projects within the unit. I think one of the things that's really important is making a decision from the beginning of prioritizing assigning projects to mentees from LMICs. So I have lots of mentees from the US, and they all get dedicated time to come and work for 2-3 months in Zambia on a project. And that's great. And I have them come. But it's really important not to penalize the LMIC mentees who don't get that dedicated time and don't have that institutional support. And so even though it takes longer for a project to be done, even though it takes more work for a project to be done, really deciding upfront that making sure that all of my LMIC mentees have a project that's theirs, that they have ownership of, is important to me. And I think talking about authorship early and often and making sure that our LMIC trainees have the opportunity to be first author, to be the presenting author at conferences is really, really essential. And I think as a mentor, one of our roles is being a sponsor, right, of networking for our mentees, of giving them opportunities. And that's true for all of my mentees, but I think that's especially true for my LMIC mentees, for whom my connections to a US network are even more important, and making sure that I'm focusing on sponsoring them for those opportunities. And then, we mentioned that there are very few mentees and many LMICs, and so you have to be flexible with topics. I've mentored many mentees on stroke, MS, neuroinfectious disease, and medical education, all of which are interests and passions of mine. But I've also mentored on headache, Parkinson's disease, epilepsy, functional neurologic disorders, and neuropalliative cares, none of which are expert topics for me. But if I don't do it, there's no one else to do it. And I've learned a lot in doing it as well. So I think we have to be flexible with ourselves, with what projects we're willing to take on when we mentor trainees from LMICs. And then I think it's important to know that geographic barriers do not have to be real barriers when it comes to mentorship. So I've been lucky to have mentees from across the continent. Dr. Yohani Gadama is from Malawi and is the recipient of an MSIF McDonald Award on which I mentored him. Dr. Fifi Duodu is from Ghana and received a Dupree Award from MSIF. Dr. Nana Badu is from Ghana and recently won the Best Abstract at the African Stroke Organization Conference for a project we worked on together. Dr. Nicholas Kulaba is from Uganda and is in the most recent Talents cohort on a project that I'm mentoring him on as well. And so I think just putting this together, I think first of all, I want to recognize that I'm preaching to the choir and that all of you here, I'm sure, are mentoring in many ways. And I just want to say again that mentoring matters. It matters everywhere, especially in the times that we're in, when many of our junior colleagues are really worried about what the future of academic medicine looks like. And I think it particularly matters in low and middle income countries. Building equity through mentoring and LMICs requires intentional commitment of time, resources, and prioritization. And I think just in general, given the times that we're in, I tell people my daily act of resistance is just to do the work that I'm doing that I know is important and not be dissuaded from that. And so I just want to leave everyone with the thought that our work matters now more than ever, and just continuing to stay in the fight is important. And so I'll leave you. This is a picture of Victoria Falls, one of the 7 natural wonders of the world on the border between Zambia and Zimbabwe. And I'm happy to take any questions and happy to receive emails as well. Thank you so much for your attention.
Questions for Dr. Saylor? Dr. Andrella.
Thank you. I've been following your career and your work. Now I've been honored to be the editor-in-chief of SEQUINS journal. And sometimes even in my prior work as a reviewer and now as an editor, I struggle with the question of we receive good ideas in papers, but they are not to the quality of being accepted. So what do you think that it could be a nice pathway of mentorship from publications for to increase representation, geographic representation in journals?
Yeah, this is such a difficult challenge because, again, we have so many bright scholars in countries where they just don't have the mentoring resources that are doing incredible work that is just not packaged well because of that lack of mentorship. I know Bruce and I have had conversations about this in terms of the African Stroke Organization. And this relies on the backs of all of us who are doing this work. But one of the things that I think would be great to consider would be some sort of program where you have volunteer mentors. And if you saw a paper come through that you think this is all the right elements are here, it just needs some refining, offering that author the opportunity to be matched with a mentor who could help them take it to the next level, I think would be really, really important. I think the other thing that I don't think many journals have, and this isn't exactly what you asked, so I'm now giving my unsolicited advice as well, would be some sort of standards on authorship and just in general publishing international work as far as our authors from the country where the work took place equally represented? Are they given, proper credit? Was there evidence of community engagement? Kind of those standards around what does real equitable global health research look like? And how can we enforce those standards as an academic community before publishing that work, I think is something that would be great to think through as well.
Hey, thank you for that amazing work you're doing. My question is, I don't know whether you face this issue of how many mentees can you have at a given time? And when do you set the limit as to, and how do you say no when somebody's asking you?
Yeah. No, it's something I struggle with a lot. And I think in particular in Zambia, because I always think if I say no, who will do this, right? And so I have more than I should. And it sometimes reaches a point where I become the rate limiting step in everyone's work, right? Because I have too much. And so I don't have the right answer for that. One thing that has helped is this. I showed the pictures of the first class of our graduates and how much they've accomplished. They're now getting to the point where they can be that junior mentor. And so in Zambia, I no longer really take on primary mentees anymore. I work with our cohort that is graduated and getting more experience, help people who come to me find the right one of them to work with. And then I'm sort of the second layer of mentorship. So I'm still involved, but I see near final drafts of papers and near final drafts of proposals after they've worked with the junior mentors. And so that has really helped. But it is definitely a constant struggle to figure out, am I doing more harm by saying no or by saying yes when I know that I don't have the time to really commit well to this mentee?
Good.
Yeah.
Well,
Thank you for your talk. You do a lot of interesting work, and I thought your talk was really helpful in just kind of understanding the scope and the need that's globally. I've always been interested in global health aspects too. And I was wondering, when did you decide to transition in your career as far as taking on global health initiatives? And so, because from what I understand, are you living in Zambia now? And like, how did you choose the country that you're working in? And like, what was the community engagement efforts that you did before you kind of made that full transition? Or like, what led you to that full transition, actually?
Sounds like we need to have coffee. But I think a very summarized, I was lucky to have a global health experience in medical school that was really formative. Came back from that experience, that was in Kenya, came back from that experience thinking maybe I want to do global health as a career, but that experience had only been 6 weeks. And so thinking that I really hadn't spent enough time to make that decision. So I took a year off between third and fourth year of medical school, went back to Kenya on a research year, and then came back from that thinking, yes, I want global health to be part of my career in some way. not sure exactly what that would look like. As a resident, I was able to stay involved in global health research and started to realize that while I loved research and still do, that what I really felt was missing in Africa in particular were neurologists, and that I thought the way to make a long-term difference was to help build a training program in a country that didn't have one. Zambia was a place where there were US investigators working in neurology research, but there was not a big clinical presence there. But the Zambian government was starting to prioritize specialist training in country. And my mentors who were doing research work in Zambia let me know that that was something that the government was prioritizing. And so as a fellow, I wrote a curriculum for a neurology training program in Zambia and submitted it, and it was accepted. And then I got funding to go, and I had a husband who was willing to move across the world with me. And so everything sort of lined up. Zambia, as I mentioned, I'm neuro ID trained. In my prior life, before I started focusing on stroke, I was doing neuro HIV work. So Zambia was a good fit for that. But we actually basically moved to Zambia sight unseen as far as the decision to move there full time. So it just kind of one thing led to another and everything kind of fell into place.
Thank you for the talk. That wonderful. And I have a question, maybe it's a little bit different. So we're part of a group that looks at Lewy body dementias, and one of the things that we find in the research, and Dr. Byram has talked about this, is that we don't know what happens with Lewy body, to give an example, across the world, right? So we have had some initiatives to try to reach out other people, and it's always been very difficult to get people involved. So how do you have any suggestions from the other side, from people that want to engage, like people from Africa in this case, and have been unsuccessful? What would be a good way of trying to engage people? Because maybe it's not so much for mentoring. Mentoring can be part of it, but at least integrating them to a larger community.
Yeah, I think this is a great question. And I think one of the main limitations I see when people reach out to engage is that they would like us to engage without providing any resources for engagement, right? And that's challenging in any setting. But when you're at a US university and you're not seeing patients full time, and you can kind of fudge a little bit how you spend your time, and your effort doesn't have to be exactly devoted the way it is on paper, there's a bit more of a fudge factor, right? And there's electronic medical records where you can go back and do something retrospectively very easily. And we often get people reaching out and saying, oh, you shouldn't even need to enroll participants. Everybody else was doing this with electronic medical records. Well, we have paper charts and they go home with the patients, and so there's no way for us to do that. But yet there's no resources actually given to us to engage. And then when you say that you need the resources in order to be able to engage, people treat you like you're trying to make money. And it's like, oh no, we actually don't, we literally don't have the infrastructure to do this. And so I think an awareness of the daily barriers and finding ways to offer the resources that people need to be meaningfully involved is the key.
Yes. Wonderful talk. Everything is there. My question is the question you asked us. How do you tell young folks in these discouraging times to persevere? You've got that beautiful message, but how do you respond one-on-one when you get that question?
Yeah, I think the first thing that I do is admit that I'm scared too. You don't want to make people think that their concern is unwarranted. And I admit that I'm uncertain and I'm scared about what the immediate future is. But I also say that this is something that I'm passionate about and I can't imagine not doing. And I've done it before unfunded, right? And so it's something that I'm willing to figure out how to continue to do in some capacity. It may look very different. The NIH Foreign Subaward rule just came in, and I've lost my funding at the end of this month to continue my research program. And so I had to tell my whole team that at the end of this month, I can't pay them any longer. And immediately, several of them said, well, we'll volunteer to finish data collection, And so it's not something I would ask them to to do, but it's something that I'm willing to make sure we find ways around. But I think it's both number one, acknowledging that their concern is real, and number two, challenging them to think about whether they can imagine doing anything else. And if not, that there's creative ways to make things happen, even if it looks different than the way it has looked.
So much well deserved.